As usual, wonderful lecture by Dr. Mohan, and today I am going to talk about treating to target with safety, a road to improved quality of life with insulin in people with type 2 diabetes mellitus is a part of must class in insulins. This is my financial disclosure. And what are the expectations with insulin therapy in insulin naive people with type 2 diabetes? And simplicity, efficacy, convenience, quality of life, and safety with minimal risk of hypoglycemia. And today's agenda is divided into two parts. First, part 1 is improving adherence and addressing the issues of complex and inconvenient insulin regimens. And part 2 is safety benefits of analog insulins, impact on quality of life. Coming to the adherence to insulin therapy is suboptimal in type 2 diabetes mellitus. This graph shows, bar diagram shows, the bars in grey color shows the poor adherence and the bars in blue shows the good adherence. So more than half the number of patients exhibited adherence of less than 80% to insulin therapy. So what are the consequences of non-adherence? So the non-adherence to insulins cause all-cause hospitalization and all-cause mortality. The first diagram shows the adherence in blue color, light blue color, and non-adherence in dark blue color. So the rate of all-cause hospitalization in adherent people is less than 20%, and all-cause hospitalization in non-adherent people is more than 20%, and the p-value is less than 0.001, which is statistically significant. And coming to the next bar diagram, which cause all-cause mortality, in adherent people, the all-cause mortality is very much less, that is about 4%, and in non-adherent people, the all-cause mortality is more, nearing 6%. So, non-adherence to medications in type 2 diabetes mellitus is associated with significantly higher rates of hospitalization and mortality. So, what are the reasons for insulin omission and non-adherence? So, there are so many reasons for insulin omissions. First one is too busy schedule in 20% of patients, and traveling is one of the cause for insulin omission in 18%, and skipped meal is in 16% of patients, and stress or emotional problems in 14%, injection embarrassment in 12%, and challenging to take at the same time every day in 10%, and forgetfulness in 8%, and too many injections in 6%, and avoid to weight gain, they miss the insulin in 4% of cases, and regimen is too complicated in 4%, and injections are too painful to omit the insulin in 3%. So with a busy lifestyle, regimen complexity, lack of flexibility, injection frequency, and fear of weight gain, all these factors can impact the adherence to use the insulin and to omit the insulin. The challenges of achieving good glycemic control, the complex and inflexible regimens. So 27%, this bar diagram shows 27.6% of people taking insulin at prescribed time or meals every day, and 23.1% people taking number of daily injections, and 81.4% of patients wish insulin regimen would fit daily life changes, and 54.4% of patients hard to live normal life while managing diabetes. So there is a need for insulin formulation to overcome the challenges of complex inflexible regimens. The core philosophy of person-centered care is do not match lifestyle to insulin regimens. So rather match the regimen to the lifestyle of the patient. So this slide shows insulin degraded caspart offers simplified approach to start and stay with insulin therapy. On right hand side, the patients who are on multiple OADs with uncontrolled type 2DM were put on basal insulin along with OADs, and they are intensified to basal plus basal insulin along with the insulin aspart once a day, and intensified the dose to basal insulin along with the insulin aspart twice a day, and further intensified to achieve glycemic targets to basal insulin once a day and insulin aspart thrice a day. So many injections and with at different timings became cumbersome to patient. And in the left hand side, the insulin degraded caspart, the OADs along with IDAC as once a day to start with, and if blood sugars are not controlled, we intensify to twice a day. So it is very simple to maintain and to take the insulins to achieve the target blood sugars. The flexibility with insulin administration, flexible dosing provides an obvious convenience and potential quality of life benefits, and greater therapy adherence and hence improved glycemic control. Significant implications for certain patient subgroups like elderly. The flexibility with dual action insulins, the biphasic human insulin and the IDAG-ASP, the comparison between the two insulins. So, see the difference in the flexibility in timing of administration. With biphasic human insulin, it should be taken twice a day with antipodal mix, that is half an hour before meal, whereas IDAG-ASP should be taken with major meal of the day, which need not necessarily be the same meal every day. And flexibility in meal injection time gap, 30 minutes before a meal with biphasic human insulin, just with IDAG-ASP it is 5 minutes before to 5 minutes after a meal. And perceived burden or intrusion is medium with biphasic human insulin, whereas it is low to medium with insulin degraded caspart. So in IDAG-ASP, a simple and convenient solution which is a co-formulation, so it can administered with any major meal like with breakfast or lunch or dinner. So the meal time and meal related flexibility is always there with IDAG-ASP in people traveling across time zones and in shift workers and those who rely on healthcare providers to administer their insulin during home visit, those who cannot take insulin on their own. So this is the solution for them. And power of a single solution, that is simple regimen with fewer injections than basal bolus with IDAG-ASP. Coming to the second part, safety benefits of analog insulins, impact on quality of life. So, hypoglycemia, a major barrier to improving glucose control. Many patients modify their insulin dose following a hypoglycemic event. The dark blue represents the type 1 diabetes, and light blue represents type 2 diabetes. So, in non-severe episodes of hypoglycemia, 74% of type 1 diabetes modify their insulin dosage. And in type 2 diabetes, 43% modify their insulin dosage. Whereas in severe episodes of hypoglycemia, that is L3 hypoglycemia, which requires hospitalization, and in such cases, type 1 diabetes patients 79% modify their insulin dose, and 58% in type 2 diabetes with severe episodes of hypoglycemia modify their insulin doses. So this is conducted in a total patient sample of 335 patients, whereas 202 are type 1 diabetes and 133 patients are type 2 diabetes. And many physicians would treat patients more aggressively if there was no concern about hypoglycemia. The GAP study, a global internet survey of patient and physician beliefs regarding insulin therapy, 1,250 physicians. The x-axis shows the proportion of responders and the y-axis shows the primary care physician and diabetes specialist. 72% of primary care physicians, they go aggressively to control blood sugars. They are not concerned about hypoglycemia, whereas 79% of the diabetes specialists go aggressively to control blood sugars with no concern about hypoglycemia. The negative consequences associated with hypoglycemia. This bar diagram shows the 63.6% of patients with type 1 diabetes following a severe hypoglycemic episode. The majority of the patients reported increased fear of future episodes, and whereas 84.2% of type 2 DM patients, they same express the fear of future episodes, and they develop some anxiety and several consequences with following the severe hypoglycemia. So we look at the potential consequence of fear. First one is chronic anxiety, and second one is quality of sleep. They get poor sleep and affects normal domestic and social life, and diminished ability to differentiate between anxiety and hypos, reducing time to react, and dosing irregularities, and reduced overall quality of life. So, socio-economic consequence of hypoglycemia leads directly or indirectly becoming economic burden to the patient. Direct cost is ambulance, hospitalization, and frequency of self-monitoring of blood glucose, emergency care, and physical visits. And indirect cost is absence from work, work disability, reduced working capacity, and accidents. And value of the insulin analogs in these cases. These hypoglycemia benefits. Fewer short-term effects of fear and anxiety and sleep disturbance, and fewer long-term effects like negative impact on employment and leisure activities. Potential to reduce out-of-pocket expenses from the patient perspective related to the need to travel to healthcare services for support following a hypoglycemic episode. Do we have evidence from randomized controlled trials and real-world evidence studies showcasing benefits of simple and convenient new generation insulin like IDEC-ASP? Yes. Insulin intensification, IDEC-ASP versus basal plus bolus insulin. This is a randomized controlled trial. In this 532 patients with type 2 diabetes uncontrolled on basal insulin were selected, and 267 patients were put on insulin deglutic aspart once a day along with existing OADs, and 265 patients were put on insulin glargine U100 once a day plus insulin aspart once a day along with existing OADs, and the trial period time is from 0 weeks to 38 weeks. After initiation, the intensification is done after 26 weeks. The IDEC as once a day, make it twice a day along with existing OAD, and insulin glargine U100 OD plus insulin aspart once a day or twice a day or thrice a day along with existing OADs from 26 to 32 weeks and 38 weeks. After 38 weeks, we look at the results. So IDEC has achieved similar improvement in HbA1c compared to basal plus bolus therapy. IDEC also provided similar fasting plasma glucose control as compared to basal plus bolus therapy. So once a day IDEC versus basal plus regimen. So first graph shows the x-axis shows the time in weeks from 0 to 38 weeks, and y-axis shows the total daily actual insulin dose. The grey color represents the insulin glargine plus insulin aspart, that is basal plus. So the starting from 40 units from the initial starting period from first week, and gradually increased, the dose is gradually increased to 80 to 90 units at the end of 38 weeks, whereas it is less with insulin deglutic aspart after 38 weeks. So there is a 12% decrease, that is significantly lesser dose requirement is seen with IDEC once a day when compared with the basal plus regimen. And coming to the second slide, this is about nocturnal hypos. The from number of episodes per subject is more with basal plus regimen. It is constantly increasing after 16 weeks to 38 weeks, whereas with the IDEC after 26 weeks there is significant reduction in the occurrence of the nocturnal hypoglycemia, that is 45% significantly lower risk of nocturnal hypoglycemia, but at the end of the treatment, that is 38 weeks, there is a decrease in 39% decrease in lower risk of nocturnal hypoglycemia is seen with IDEC. And T2DM switching to IDEC from basal insulin. This is real world evidence. The basal insulin here is glargine U100 or U300. 236 patients were selected. They are switched to IDEC. So the proportion of patients who state that they are willing to continue IDEC is the 232, and the blue color represents 78.8% of patients. They say yes to switch over to IDEC, and 19.5% said no, 1.7% it is not applicable, and the 74.2% of patients who stated that they are preferred IDEC to previous treatment, and 22.5% of patients said no to change to IDEC, and 3.4% it is not applicable. And switching to IDEC from basal insulin resulted in improved quality of life in patients with uncontrolled diabetes. So the diabetes therapy related quality of life scores at baseline and 26 weeks after IDEC initiation. The grey color represents the baseline and blue color represents the end of the study. The baseline HbA1c is more than 7% and less than 8% in 106 patients. They show 69.1% show quality of life. It was increased to 72.2% at the end of the study. They said they improved the quality of life. And when the baseline HbA1c is more than 8%, only 63.63% so showed the quality of life, whereas at the end of the study with the gas, 68.4% showed the improvement in the quality of life. The total diabetes therapy related quality of life score improved significantly from an observed mean plus standard deviation of 67.3 plus or minus 16.3 at baseline to 70.6 plus or minus 16.1 at the end of the study. Estimated change is 3.4. And this slide shows the ida gas versus basal insulin, that is insulin glargine. So overall confirmed hypoglycemia. There are so many trial studies, that is Shimoda et al. 2019 and Kumar et al. 2016 A and B, and Omishi et al. 2013, Hesh et al. 2011, and fixed effect models. These studies shows risk of overall confirmed hypoglycemia in the OD ida gas group was similar to the OD basal insulin. And coming to the second slide, overall confirmed hypoglycemia in the following studies: Kumar et al. 2016 A and B, Omishi et al. 2013, and Hesh et al. 2011, and random effect models. The risk of nocturnal confirmed hypoglycemia in the OD ida gas group was significantly lower to the once a day basal insulin. So nocturnal hypoglycemia is less with ida gas when compared with the basal insulin. Coming to the SMART study design. So here 1029 patient adults with type 2 diabetes mellitus was selected in this study, and participants received ida gas, and data was collected at the end of 0, first and third month, 6th month, and 12 months. And study information, this is a multi-center, prospective, single-arm, observational, and PMS study. Key inclusion criteria are men and women with diabetes mellitus aged more than 18 years, scheduled to start treatment with ida gas based on clinical judgment. So change in HbA1c from baseline. This graph shows, the x-axis shows from 0 to 12 months, and y-axis shows the mean HbA1c percentage. Before initiating the ida gas, the mean HbA1c is 9.5, and after 3 months it has come down to 8.3. After 6 months it has come down to 8.1, and after 12 months it was 7.7. So ida gas showed effective control of HbA1c with 1.8% reduction. So in insulin treated patients, when the HbA1c is 9.9%, the reduction of HbA1c is 1.8%, whereas in cases of oral antidiabetic drugs treated patients, HbA1c is 9.3 and the reduction of HbA1c is 1.7%, and 73% with OADs are on OADs, and whereas 27% on insulin. And coming to change in fasting plasma glucose from baseline. This graph shows the fasting plasma glucose before initiation of ida gas is 180.4 milligrams per deciliter. After 3 months, it has come down to 143.7 milligrams per deciliter. After 6 months, it was 134.8, and after 12 months, it has come down to 130 milligrams, that is up to the target. So baseline fasting plasma glucose 180.4 plus or minus 59.7 milligrams per deciliter. At the end of the study, after 12 months, 130, it has achieved 130 milligrams plus or minus 33.1 milligrams per deciliter. Mean change in the reduction of the fasting plasma glucose is 50.4 milligrams per deciliter. So change in the postprandial glucose from baseline. Here comes the post breakfast and the post lunch. The graph shows the two. The square shape shows the post breakfast and round shows the post lunch lines. The post breakfast, before the initiation of the ida gas, it was 266.9 milligrams per deciliter. After 3 months, it was 12.7 milligrams per deciliter. After 6 months, it is 199 milligrams per deciliter. After 12 months, it was 184.4 milligrams per deciliter. That is, after post breakfast, the baseline postprandial glucose 266.9 plus or minus 77.8 milligrams per deciliter. At the end of the study, it has come down to 184.4 plus or minus 47.2 milligrams per deciliter. Mean change in the glucose is 82.5 milligrams per deciliter. That is up to the target. And coming to the post lunch, at the beginning it was 254.8 milligrams per deciliter. After 3 months, it has come down to 182.3 milligrams per deciliter. After 6 months, 187.7 milligrams per deciliter. After 12 months, it was 180.6 milligrams per deciliter. So, post-lunch, baseline postprandial glucose 254.8 plus or minus 84 milligrams per deciliter. There is a decrease of 74.2 milligrams per deciliter in the glucose. At the end of the study, the postprandial glucose is 180.6 plus or minus 40.1 milligrams per deciliter. So, very few patients had their post-dinner values recorded in this study. So, reduction in the number of hypoglycemic episodes. So, the red color shows the bar shows the confirmed hypoglycemia. The 176 episodes occur in the immediate 4-week period before starting ida gas in the first visit. After initiating the ida gas, the subsequent hypos have come down. In the second visit, the events are 28, and the third visit after 6 months it was 17. After 12 months it was 11 episodes. And coming to the severe hypoglycemia, events in the immediate 4-week period before starting ida gas, the events are 24. But even since the last visit, there are no severe hypoglycemia occurred in the subsequent visits. That is, after 12 months, it was seen with the ida gas. So, coming to the summary of the SMART study. Effective HbA1c reduction, that is more than 1.8% HbA1c reduction. Effective postprandial glucose control, 82.5 milligrams per deciliter reduction post breakfast and 74.2 milligrams per deciliter reduction post lunch. And effective fasting plasma glucose, 50.4 milligrams per deciliter reduction from baseline. This shows the total control, both fasting and postprandial and HbA1c reduction is achieved with the single shot ida gas injection. So, improved safety with low risk of hypoglycemias. So coming to the summary, multiple factors impact adherence to therapy and patients prefer simplicity and convenience. And insulin therapy, if complex, has its own limitations. As a result, an insulin regimen that fits into patient's life helps offer better glycemic control through improved adherence. ADEC offers total glycemic control with simplicity, convenience, and lower risk of hypoglycemia can thus improve the overall quality of life. Thank you. Coming to the second part of this session, the case scenarios. Understanding the clinical benefits of choosing an optimal insulin therapy. The first case, the patient uncontrolled on multiple OADs, Mrs. Shalini Verma, who is working as a teacher, 54 years old female. Her BMI is 24.2 kilograms per square meter. She has diabetes since 8 years and current complaints, burning, pain and numbness of feet. That is, she is suffering from diabetic peripheral sensory neuropathy and diagnosed with hypertension 5 years back, and her lifestyle is carbohydrate rich meals, erratic eating patterns and busy lifestyle. And current medications are sitagliptin, tablet sitagliptin, bar metformin 50 bar 1000 milligrams twice a day, and glyclazide XR 60 milligrams once a day, and tablet atorvastatin 20 milligrams once a day, and telmisartan 40 milligrams once a day. And our HbA1c is 9.6%, fasting plasma glucose is 220 milligrams per deciliter, and postprandial glucose, that is post breakfast, is 290 milligrams per deciliter, and post dinner it is 262 milligrams per deciliter. This case shows abnormal blood sugars with uncontrolled type 2 diabetes, and she has hypertension, 3 comorbidities: diabetes, uncontrolled diabetes mellitus, hypertension and dyslipidemia with microvascular complications, neuropathy. So Mrs. Shalini Verma was counseled for insulin initiation. For successful initiation, so discuss device and chosen regimen. So we have to discuss about the various types of insulins and dosages and regimens. We have to explain all, and we have to give the choice to her to select the insulin. And next, injection sites. We have to discuss about the injection sites where insulin has to be taken, and we have to tell about the rotation of the site, which is very important to prevent lipoatrophies and lipodystrophies, and to discuss about the starting dose and time for the first dose and how to titrate the dose. And next one is oversee the first injection and first injection. So first we have to demonstrate how to take the injection, and we have to see how she will inject, whether she is taking perfectly or not. And to provide basic information regarding insulin storage, where she has to store the used ones or unused ones. The insulin should not be kept in the freezer. It should be stored between 2 to 8 degrees centigrade. So second one is hypoglycemia. We have to tell about hypoglycemia and how to contract the hypoglycemia, and to prevent the hypoglycemia we have to advise her to take small frequent meals, not only the 3 major meals, and she has to take early morning snack, mid morning snack, evening snack and late night snack to prevent hypoglycemias. And we have to give the emergency numbers to contact whether she underwent any hypos, and we have to discuss about the sick day rules and discuss ongoing support in the coming days and beyond and address any concerns. So Mrs. Shalini Verma was initiated on biphasic human insulin as she selected biphasic human insulin. So we started her on biphasic human insulin 8 units before breakfast and 4 units before dinner. And tablet sitagliptin metformin was continued along with the drugs for hypertension, and glycoside was discontinued. In the weeks after starting insulin, it is important to ensure that the dose is appropriate and titrate if necessary. Refer the patient to a patient education program if available. Reinforce the information given at the first appointment. Telephone consultations can be useful in achieving these goals. So, the Mrs. Shalini Verma, who is on multiple OADs uncontrolled, was put on biphasic human insulin. How to titrate the insulin and how are the blood sugars, we will see in this chart. At the beginning, we started the insulin at the dose of 80 units in the morning and 4 units in the night, and we escalated the insulin to 22 units in the morning and 10 units in the night after 8 weeks. And after 12 weeks, it is 24 units in the morning and 10 units in the night. The fasting plasma glucose is 220 in the beginning, and after 8 weeks it has come down to 162 milligrams per deciliter. After 12 weeks it was 154 milligrams per deciliter, which was not up to the mark, not target. And post breakfast the blood sugar was 290 milligrams per deciliter. After 8 weeks 236 milligrams per deciliter, and after 12 weeks 208 milligrams per deciliter, and post dinner 262 milligrams per deciliter at 0 week, and after 8 weeks it was 204 milligrams per deciliter. After 12 weeks 190 milligrams per deciliter, and her HbA1c is 9.6 in the beginning and it was 8.6 after the 12 weeks. This shows the blood sugars as well as HbA1c were not up to the target with the biphasic human insulin. So current treatment challenges. One is HbA1c is 8.6%, poor glycemic control, that target HbA1c is 7%, and therapy not suitable to patient's busy lifestyle. She would skip or have little breakfast at times and mistimed meals for the reasons. So current treatment challenges. One is hypoglycemia. Mrs. Shalini Verma complained of intermittent episodes of dizziness during pre-lunch period as she takes little breakfast and sometimes at night. So sweating, waking up with damp clothes or sheets, waking up with headache, nightmares, these are all the symptoms of the hypoglycemia. So what were the issues with the insulin used in this case? Lack of flexibility of dosing, diurnal and nocturnal hypoglycemia, fluctuating glycemic profile, and compromised quality of life. Could this be avoided by initiating this patient on a co-formulation? Let's explore. Yes. So, we'll see another case of uncontrolled diabetes on multiple OADs. That is Mrs. Radhika Kapoor, and she has a similar profile and baseline characteristics as Mrs. Shalini Verma. So, in this case, we initiated with insulin degludec aspart 10 units at breakfast as major meal to improve the patient's glycemic control, to lower the risk of hypoglycemia, and to provide the flexibility in the dosing regimen. So this slide shows the insulin dosage was started with 10 units in the beginning, After 8 weeks, we made it intensified to 20 units in the morning and 8 units in the night. And after 12 weeks, 22 in the morning and 8 units in the night. The fasting plasma glucose 220 in the beginning, and after 8 weeks 140, it has come down to 144. After 12 weeks 128, absolutely up to the target. And post breakfast it was 290 milligrams per deciliter in the beginning. After 8 weeks it was 204, and after 12 weeks it was 176 milligrams per deciliter, that is within the target. And post-renal blood glucose is 262 milligrams before initiation of high gas, and after 8 weeks it has come down to 184 milligrams per deciliter. After 12 weeks it has come down to 168 milligrams per deciliter, which is absolutely normal. So her HbA1c was reduced from 9.6% to 7.6. So much is difference with Ida gas and when compared with the biphasic human insulins. 1 year later, Mrs. Radhika Kapoor has HbA1c 7.2% with no episodes of hypoglycemia, improved sense of well-being. She has learned titration and prefers the ease of delivery device. Quality of life has improved. So coming to the summary, individualizing insulin therapy and choosing the right regimen is important. Treatment with Ida-Gast with major meal helps in controlling both fasting plasma glucose and postprandial glucose levels. Ida-Gast offers lower the risk of hypoglycemia. Ida-Gast is a simplified approach to start and stay with insulin therapy with minimal amount of hypoglycemia and nocturnal hypoglycemia. Thank you for your patient listening.